Good afternoon, everybody. It's an absolute privilege and pleasure to be back here in Nottingham. For those that I haven't had the privilege of meeting yet, I'm Izzy Lieberman. I'm an orthopedic and spinal surgeon who now works in Dallas, Texas. I spent my fellowship year here in 1993 with Mr. Mahedian and Mr. Webb, and I want to thank them for the invite back this year, first of all, and for the tremendous education that I got during the year that I was here. What I'd like to share with you today is some of the work that I've been doing over the last number of years on robotics for spinal surgery. It's a growing field, it's an exciting field. The more people involved, the better, so I'd like to encourage anyone that's interested in this to get involved in some of this work, because it really is the way we're going to be going on things. In the spirit of disclosures, I do have a relationship with the company that makes the robotic device. It's Mazor Surgical. I was involved in the early design development. My name's on some of the patents of the device as well, so you're going to get a very biased opinion about this from me. Now, I look at surgery just like marriage. It's all about control, and as surgeons, we don't ever want to be in this kind of a position where we regret what we may have done or where we may have placed that implant or placed that screw. Control is critical, and this is what the robotics allows us to be, is in more control during surgery. Now, everywhere we go today, there's some kind of automated process, some kind of automation, something. Our bags at the airport are being sorted by robots. The cars that we drive are being made by them. The cell phones that we use are being made by them. So it's out there. It just hasn't hit the operating rooms as efficiently yet. But there are multiple different types of robots. There's the semi-active or passive robots that will position you in three-dimensional space. There's robots that are more active that will actually perform the procedures for you. And then there's the robots that mimic the surgeon's action, or remotely the surgeon can be positioned and can do the action at someplace else, much like some of these commercial robots that are available. What I'm going to be talking about is this device here. It's a parallel manipulator that positions you in three-dimensional space and provides the trajectory for you to place the implants that you want to place into the spine. And it's quite unique. It's a small device, and it's got these 6 pistons inside, and the 2 plates just move up and down. So the engineering is not that remarkable, but when you get the concept of it and the magic behind the referencing, that's what really makes this quite unique. So the system itself does support both open, minimally invasive, or percutaneous procedures. It does provide for accurate and controlled placement of the implants, and it really makes the surgery much more efficient. Now, over the last number of years, and you're going to hear me emphasizing this over and over again, the one thing that I've learned with all the work we've been doing here is preoperative planning. When I was a fellow here, at the insistence of Mr. Mahedian and Mr. Webb, we used to take tracing paper, cut the tracing paper into wedges, and figure out how we're going to correct the spine. And that was years ago, but now with this technology, we're able to preoperatively plan, and you're going to hear me talk about this a couple times. But the components of the system are the preoperative planning software, the workstation itself, which is in the operating room, various different bone mounting mechanisms to support the robot itself, and then the robotic device itself. So the procedure flow is, again, the preoperative plan. You set up in the operating room, you register, and then you do the surgery. Now, if you hired a contractor to come in and redo your kitchen or your washroom, and he said, yeah, I'm going to put a light here, I'm going to move the sink here, I'm going to put the wash basin over here, and he didn't show you a blueprint, would anyone in the audience hire that individual? No. How about a pilot? If you heard that a pilot didn't do his pre-flight plan, didn't take into account the weather, the geography, the payload, the fuel, would you get on that plane with him? No. Well, for years, our patients have been coming to our operating rooms, and we have not had a pre-op plan. And this is so important now, and this is really the biggest difference that I think with the new technology that we have, that we can preoperatively plan and make things much more precise and efficient. So this is what we do ahead of time. We get the CT scan done, And the CT scan is loaded onto your laptop, onto a desktop, onto the workstation itself. And you can see I'm positioning the implants in three-dimensional space. I'm positioning the screws exactly where I want them, in the trajectory where I want them, making sure that I'm not hitting any critical or vital structures. I can change the size of the screws. I can change the diameter of the screws. And then we can do this at multiple levels throughout the spine. This is a virtual model, so I can check the position of those screws in the sagittal plane, in the coronal plane, and then in the axial plane. And we can actually do it slice by slice, so we can position it very, very precisely, and then we can move it according to the reference frame that we want, and then check our positioning in all three planes. So here you can see I'm going slice by slice in the axial plane, making sure that I've got the depth of the screw appropriate, the position of the screw appropriate. You can see that screw on the left-hand side is just a little too close to the spinal canal, so I'm going to tweak it a bit, just move it over to the left a tiny little bit, and we look at it and verify and do all of this ahead of time. Now, some have criticized me for this part of it, saying, well, this takes too long, no one wants to take the effort, but the effort now pays off in the operating room. It takes me about 5 to 10 minutes to plan a 2 or 3 level case. It takes me about 25 to 30 minutes to do one of our Scoli cases. But the efficiency in the operating room, well worth the cost of that ahead of time. And then there's other advantages that we'll point out in a moment as well. Once you've got the plan done, you've got what's called the summary details. And I print this off and I give this to my circulating and scrub nurse, so they prepare all the implants ahead of time. We know exactly what we're going to be using before the surgery itself. In the operating room, our X-ray tech sets up the C-arm, and then we do our exposure and decide which system we're going to use to mount the robot. And essentially this is the one that I use the most. It's what we call the hover T frame, and the robot just crawls up and down this rail, and you've got the various arms on it. Once we've got it set up, we have to register. And this is where the real magic in the software is. All we need to register is an AP and an oblique intraoperative X-ray, and that's matched to the preoperative CT scan. So right off the bat, you are saving a tremendous amount of radiation exposure to yourself, to the patient, and to the OR staff. So we put the reference frame on, we take an AP and an oblique X-ray, and this is what we get. The X-ray is then matched with the pre-op CT scan, and the computer labels the vertebral bodies and says, is this L1, is this L2, is this T12, is this T11? And what we then have to do is just verify. Once we verify, we get a score of how accurate the matching is. And here you can see the score is 0.46 millimeters accuracy with the matching. So we know that we're right on and we've identified the vertebral bodies. At this point, we pick the screw we want to implant, and the robot and the workstation gives us the instructions as to what we need to do according to that pre-op plan. So here's just a little video. Hopefully it's running good. The video is running. So you can see we take the robot, it's placed into a plastic drape, it's mounted onto the frame itself, and then the instructions tell us which arm, which tool to get the appropriate trajectory to where we need to be, and the robot moves in three-dimensional space. And the first time you do this, it takes a little bit of a leap of faith. Now, for those who have done percutaneous procedures, vertebral augmentations, perc screws, it's a little easier. You get down, you can feel, you try to pre-plan your landing point precisely, and then you drill, you tap, and you can use essentially any implant system through this. If you want to use a K-wire cannulated type system, a fixed system, you can just get it down and you implant all your screws. So you connect your arm, you insert your guide tube, you use a blunt obturator, you tap, and then you repeat for all the different trajectories. So this is just one example that I had done recently. This is a Scoli young girl, 14-year-old, with this progressive curve, and you can see the extent of her curve. And here's the preoperative planning, and this is why, again, I think it's so important. Look at her pedicle up here. This is a whisper. She doesn't even have a pedicle up here. But with the pre-op planning, I can position that screw and still get it in and get good purchase and use that as needed. So you can really recognize a lot of subtle anatomical variants that you may not know of if you hadn't examined or looked at the pre-op plan ahead of time. So here's the procedure itself, multiple screws in place, and here's the final correction, screws at every level, regaining your sagittal and coronal balance, all done with a guidance type system. This is another case, an Ank Spawn case, where we were doing multiple level osteotomies. You can see someone had decompressed him already and he had a pseudoarthrosis at 4-5 that I was going to take advantage of. But because of his sagittal imbalance, what I decided is I wanted to anchor him down into the pelvis. So again, with the preoperative planning, I can plan S2 alar screws into the iliac wing with good purchase all the way along to give me a solid foundation and end up with this kind of construct and really get him where he needs to be with solid fixation down there. So we did a whole bunch of work on this in the validation period, and we did a lot of pre-op scans, post-op scans, and you can see this is a pre-op scan laid on my, the post-op scan laid on my preoperative planning, and you can see the screws are essentially in the same spot that we had planned them with. There we go. So there have been a number of publications out at this point. This is a publication that we had a couple years ago where we took a bunch of surgeons and we put them through, this was a cadaver study, and the first thing we found was far less radiation when you were doing it with the robot as opposed to the freehand. And what really kind of disappointed me was that pedicle screw placement accuracy was not dependent on surgeon experience. We had first-year residents, senior residents, fellows, junior staff, and senior staff involved in this. And the accuracy was the same. So the junior residents were putting screws in as accurately as the designers of the system, which kind of hit my ego a bit, but so be it. Kandelhart out of Germany published this paper, 57 freehand cases versus 55 robotic cases, and he concluded that in the robotic-assisted procedures, the rate of misplaced screws and the duration of intraoperative X-ray exposure were significantly lower, while procedure times didn't really differ. So even with all the extra stuff that we thought we were doing with the robot, the procedure time was still very, very efficient with these. Mitch Hardenbrook published and presented this paper where he had 98.9% of the screws implanted accurately, and it really demonstrated the feasibility of this. And then Dennis DeVito presented this first at the SAS meeting, his 80 adolescents with 99.9% screw accuracy in 1,100 screws, and he felt that it provided a safe approach to it. And then we went on to publish this, 840 cases, 14 hospitals with over 3,000 pedicle screws, and again, 98% of the screws were clinically acceptable in terms of their placement. So the procedure, the robotic guidance did enhance the surgery. So when I'd moved from the Cleveland Clinic down to Texas Back Institute, we started looking at all our cases in a prospective fashion. And this was a publication that actually just came out earlier this year, looking at our first 102 cases. And we wanted to really review my experience with it and the learning curve, essentially, to see what we gleaned from all that. So it was a consecutive series from June 2010 to December 2011. Virtually all of these were complex deformity cases, revision cases, or tumor cases. The notes were taken, and I had an independent research associate who looked at everything, so I wasn't involved in any of the analysis of this. And we classified the screws as successfully placed. Screw was malpositioned using the robot. We didn't use the robot, and the screw was placed manually, or I elected to not place screws because I didn't feel it was needed for the construct. So we were able to use the robot successfully in 95 out of the first 102 cases. Again, 90% of which had some kind of spinal deformity. There were 1,085 screws placed, of which a quarter of them were percutaneous or MIS placed. 11 of those screws, so 1.1%, were malpositioned, and I'll show you some of the issues with that. 110 screws we converted to manual placement, and I'll also show you why we did that. And then I elected not to place 15 of them, and then we did have one patient with a neuropraxia where the screw was removed 2 days after. So here's sort of the histogram looking at how successful we were with the initial placement and why we had to abort or manually place them. But this is what I found very interesting. This was the learning curve, where we divided into the first 375, then the next 300, then the next 300 screws. And you can see successfully placed went up, converted to manual went down, and that's because I learned more about the limitations in the preoperative planning and the patient selection. But this is the issue here. Still 1% screw malplacement rate throughout the whole learning curve. So very, very accurate. We're still able to get things where we need to be. So this 1% was because of what we called skiving, where we didn't plan well enough or seat the drill well enough, and it just sort of slid a little bit off the side of the bone or off the side of the facet. And we've now got devices where we can burr down a little pilot hole. We can prevent that skiving. And again, one of those screws I did have to remove. Now, 110 of the screws were converted to manual, and that was over 7 cases. One case was an individual with a body mass index of 45. He was 6'6", just a huge human being. I thought we would be able to do it, but we just could not get the intraoperative x-rays on him. We had another patient that was severely osteoporotic. Again, couldn't get the intraoperative x-rays to match. We had one severe deformity, this young girl here, and essentially what happened, the computer couldn't figure out the T4 vertebral body from the L4 vertebral body because the x-ray overlapped it. So these were sort of the things that we learned in those first group of cases that we went on to change. Now here's the accuracy issue again, and what we did is look at the revision cases, because this is one of the areas where I felt this is going to be very, very valuable. In revision cases, you lose the anatomy, it's a difficult dissection, you never really know where you are in three-dimensional space with these things. So we divided these out again and looked at all these cases, and one more time we saw that even in revisions, the malposition rate was still less than 1% by and large across the spectrum of all these cases. So we felt that the robotic-assisted placement was successful, less than 1% screws of malposition. If you look through the literature for the complex deformities, it's anywhere from 4.2 to 15.7% malposition rate. Intraoperative fluoro registration is critical. I can't emphasize that enough. You have to be able to get good x-rays or you're not going to be able to do this. Tool skiving was the issue with those malpositioned screws. And I bring up this paper that was presented at the North American Spine Society last year, which by this group by Prosciutti from Hartford, Connecticut. They followed some adolescent scoli patients and looked at the radiation exposure to these patients. 267 patients followed for a minimum of 2 years, divided it into observation, bracing, and surgery. And look at these numbers. The patients they observed got exposed to 274 millirads per year. The patients they braced had 446. But the patients that they operated on were subjected to 78,900 millirads of radiation per year. These are kids. They're 12, 13, 14-year-olds that were radiating. Now, a lot of my colleagues will put in a pedicle screw, twist it 1 millimeter, take an x-ray. Twist it another millimeter, take an x-ray. That's where they're getting this radiation from. So it may be a little inflated. But look at the maximum yearly recommended exposure is 5,000 millirems per year, and here we're giving them 78,900. And again, people have criticized the use of the preoperative planning having to get a preoperative CT scan. Well, the preoperative CT scan is about 4,000 millirads. So I'd much rather have one of my kids or my patients subjected to 4,000 millirads prior to surgery rather than 78,900 millirads during surgery, where they get 99% of that radiation exposure. So if anything, this is one of the main justifications for this type of procedure. So the advantages are it minimizes the intraoperative radiation exposure. It does improve screw placement, precision, screw pull-out resistance, and deformity correction. The preoperative planning definitely helps me recognize subtle anatomic variations that are there. I'm convinced that I'm a better surgeon today than I was 10 years ago because I'm looking at things much more critically, and I walk into the operating room having already done the surgery in a virtual environment. It facilitates less invasive exposures, and it does enhance the operative efficiency. But one thing I like to emphasize, robotic assistance is not going to make a bad surgeon good. What it does is it makes a good surgeon more precise and more efficient. You still have to understand the indications. You still have to understand the anatomy. You still have to have the feel. You have to know when you're in the right spot and know when you're not in the right spot. So with that, I'd just like to share with you that life is not a journey to the grave with the intention of arriving safely in a pretty and well-preserved body, but rather skid in broadside, thoroughly used up, totally worn out, and loudly proclaiming, "Wow, what a ride." I've been on this robotic ride now for 12 years. The first 6 years I thought it was just a bad video game. It was terrible. We were going through cadavers left, right, and center and not getting anywhere. But then we got a couple brilliant engineers, the technology came together, and I have no doubt that this is going to be the mainstream of spine surgery in years to come. Thank you very much.